certain subjects of clinical importance that when a clinician reads a report, he should be aware and fully aware of the fate of this baby. And my topic today is congenital CNS anomalies causing pediatric seizures, prenatal sonographic diagnosis, and clinical implications. And first, you have to know that according to the WHO, approximately 50 million people are currently affected by epilepsy worldwide, with 85% of cases found in the developing countries. And that approximately 50% of epileptic cases commence in childhood, with the highest prevalence seen from ages 1 to 4 years. Congenital CNS malformations are seen in about 40% of children with refractory epilepsy. So the introduction of high-resolution 3D and 4D ultrasound, together with tomographic ultrasound imaging, have revolutionized understanding of these malformations, providing an adequate prenatal anatomical diagnosis. And the aim of this talk is to throw the light on prenatal sonographic diagnosis of congenital CNS anomalies causing pediatric seizures and their clinical implications. Here is the spectrum of CNS malformations causing pediatric seizures, and this will include destructive cerebral lesions, agenesis of the corpus callosum, hydrocephalus, holoprosencephaly, lissencephaly, arachnoid cyst, microcephaly, and tuberous sclerosis. And you might read the diagnosis of any of these in a report. And therefore, when the patient asks you as a clinician, what I'm going to do to that fetus after delivery, at least you have to know what is the fate of that baby. The first thing is destructive cerebral lesion, and usually they have a vascular etiology. We have hydranencephaly, porencephaly, and schizencephaly. And hydranencephaly results from bilateral thrombosis of the supraclinoid portion of the internal carotid artery, and therefore the destructive is massive. Porencephaly and schizencephaly are related to thrombosis of branches of the cerebral artery, and therefore they are also destructive but less than hydranencephaly. Here is the appearance of, I hope the slide works. Here is the appearance of hydranencephaly, and in each time I am bringing the ultrasonography comparing to the MRI to see how accurate we can diagnose this prenatally. As you see here on the left side of the screen, this is hydranencephaly, and as you see, there is complete absence of echoes from the anterior and middle fossa with preservation of the midbrain and cerebellum. And this is a postnatal MRI. Both are very similar to each other. Again, we have here a porencephaly, and in porencephaly there is one or more cystic areas in the cerebral cortex. All these are destructive because of blood thrombosis leading to the coagulative necrosis of the brain. One or more cystic areas in the cerebral cortex usually communicate with the ventricle and or the subarachnoid space. And again, here is a postnatal MRI which shows you how accurately you can diagnose it prenatally. In schizencephaly, you have the same problem but bilateral, and compare it also to the postnatal appearance to see its destructive effects. The prognosis, hydranencephaly is lethal. So if you read a report with hydranencephaly, you have to tell the patient that this baby is going to die and we might terminate. It's lethal in early infancy. Porencephaly and schizencephaly related to the size and site of the lesion, impaired neurodevelopment and seizures, and we pass to agenesis of the corpus callosum. And the corpus callosum is simply a broad plate of dense myelinated fibers which intercommunicate the both cortex of the brain. It's exactly in the midline. And in absence of the corpus callosum or agenesis, we have either partial or complete absence. Here is the appearance of the corpus callosum, and you can get it manually. And here is the component of the corpus callosum, and you can get it by tomographic ultrasound imaging, a software present in your instrument, and you can see the corpus callosum here, and this is the structure of the corpus callosum, and it is directly related to a cave inside it. This is called the cavum septum pellucidum, and here is the place of the third ventricle. And I brought this manually to compare that the rostrum, genu, body, sorry for the slides, it's not working effectively, and tail. As you see, we can bring it, and you can know the place of the corpus callosum by bringing the cerebellar vermis in the midline. So you can see it exactly. Here is the manual, and here is the post-mortem appearance of the corpus callosum. A cave inside the corpus callosum is called the cavum septum pellucidum. This is the cave inside the corpus callosum, and we can see it by ultrasound like this. اللي احنا بنقول عليها علامة اليساوي دي. هي دي الكيف اللي جوه الكوربس callosum. And in agenesis of the corpus callosum, you cannot see this beyond 18 weeks. So if you did a transaxial view of the fetus, failure to visualize the cavum septum pellucidum beyond 18 weeks of gestation should raise the suspicion of agenesis of the corpus callosum. Another important sign is the presence of ventriculomegaly. The ventricle is usually dilated posteriorly. Why? Why posterior? This we call colpocephaly, because it is exactly in the midline, and the posterior part of the lateral ventricle forms an important lateral relation to it posteriorly. So if it is absent, it's going to dilate posteriorly, and we call this colpocephaly. And we can see it as a teardrop, therefore it's called teardrop configuration. A third thing, the corpus callosum forms the roof of the third ventricle, and therefore agenesis of the corpus callosum will lead to elevation of the third ventricle to lie at the same level of the lateral ventricle, as you see, and this is another sign. But the definitive diagnosis is that you get the midline and you see the absence of these components. So again, I brought the MRI picture to show you how accurate we can diagnose agenesis of the corpus callosum even prenatally. The prognosis is in agenesis of the corpus callosum, you tell the patient that this baby might suffer from some intellectual impairment, psychosis, and seizures. But some children have been reported free from neurological compromise, and the patient have to know that usually there is always subtle difference in higher cortical functions compared to individuals of the same age and education without agenesis. يعني العيانة دايما تبقى عارفة ان البيبي ده هيبقى intellectually أقل شوية من العيانة اللي ما عندهاش agenesis. Now we pass to hydrocephalus and ventriculomegaly, and ventriculomegaly is enlargement of the lateral ventricle. بنعرفه باننا نقيس الاتر ويتس بنلاقيه اكتر من 10 ملم. Hydrocephalus simply is an excessive ventriculomegaly. So hydrocephalus is a severe form of ventriculomegaly in which the atrial width is more than 15 millimeter. How to diagnose ventriculomegaly? We come to the area of the glomus or conglomeration of the choroid plexus, and we measure it. If you find it more than 10 millimeter, this is ventriculomegaly. This is called the atrium of the ventricle. This area is called the atrium because it is the entrance of the lateral ventricle into the inferior horn of the ventricle, and therefore it's called the atrium, يعني المدخل أو entrance. Now, ventriculomegaly is categorized according to the severity of dilatation of the lateral ventricle into mild, moderate, severe. And in this categorization, the risk is related to the severity of dilatation. So the severer the dilatation, the more risk. Risk of what? Risk of chromosomal anomalies and risk of neurological morbidity in the form of neurodevelopmental delay and seizures. So in isolated ventriculomegaly, you have to tell the patient that your baby is going to suffer. The higher the degree of the ventriculomegaly or the dilatation of the ventricle, the more the risk of seizures. Holoprosencephaly is another problem causing seizure, and there is failure of sagittal cleavage of the forebrain or prosencephalin resulting in presence of a midline single ventricle with variable degree of separation. And according to the degree of incomplete division, we have elobar, semilobar, and lobar type. And again, I'm comparing the prenatal picture with the postnatal picture to show that postnatal MRI can got the same result. Here is a case of another case of lobar holoprosencephaly. You can see here in that film that there is, look here, there is fusion of the ventricle anteriorly and absence of the cavum septum pellucidum, and again compare it with the postnatal MRI. Now the prognosis, elobar and semilobar holoprosencephaly are lethal. Lobar holoprosencephaly is associated with intellectual impairment and seizures. Now another entity is called lissencephaly, in which, look here, there is a normal brain, look to the sulci and gyri, and in lissencephaly we have either agyria, which means that we don't have sulci and gyri, or pachygyria, which means that we have conglomeration or thick or fat gyri. This is the definition of lissencephaly as you see in the post-mortem specimen. This is agyria and this is pachygyria. How to diagnose it? Usually the sulci and gyri develop lately. So failure to see the sulci and gyri after or from 20 هي دايما بنشوفها من 26 to 28 of gestation. Failure to see them after 26 or around 25, 26 weeks of gestation will lead to diagnosis of lissencephaly. Look here, we search at certain sites. When you diagnose, you search at the parieto-occipital fissure in the transaxial view. Here you will not find it in lissencephaly. Here is the normal appearance, here is absent. And we search for the convexity sulci, and this is the normal appearance, and in lissencephaly you don't see such a convexity sulci. Again, in a transaxial plane, you search for the sylvian fissure and insula, and you do not see them in lissencephaly. And in the coronal view, you search for the calcarine fissure, and you do not see in lissencephaly. And this is the last case of lissencephaly I have diagnosed about 3 months or 4 months ago. One of the important things is that you find a great distance or marked distance between the smooth brain and the cranium. As you see here, the distance was more than 7 millimeters. It's usually 1 to 2 millimeters. Here is this distance. And secondly, look here, you do not see the parieto-occipital sulcus, you do not see the convexity sulci, you do not see the insula and sylvian fissure. And here is the place of the parieto-occipital sulcus, and here is the place of the insula and sylvian fissure in a fetus which was around 25 weeks. And look, when you compare again the normal brain with the lissencephaly, this is the appearance of the ultrasound. See how similar to the postnatal appearance, which means all these things could be diagnosed prenatally, easily. Now, the prognosis is generally poor, severe mental retardation, infantile spasm and seizure, reduced chances for survival. Death usually occurs in the first 6 years of life after يعني حياة بتبقى very troublesome for the mother and father. Microcephaly, head circumference more than 3 standard deviation from the normal, and usually you have a sloping forehead and a ventriculomegaly. Again, this is another cause of neonatal seizures, and the prognosis is much poorer if you found in your report that the head circumference is more than 4 standard deviation below the mean. And finally, tuberous sclerosis, and I have seen 3 cases in my life of tuberous sclerosis. This is one of them. In tuberous sclerosis, tuberous comes from the Latin tuber swelling, sclerus means hard, so it's a rare multi-system genetic disease. It causes thick, firm, hard, benign lesions to grow in the brain and other vital organs such as the kidneys, heart, lungs, and skin. And what aroused the suspicion in this case is that you find the same lesions in the brain and in the heart. In the brain, it causes benign tumor astrocytoma. And here is again the postnatal MRI, and in the heart, it causes rhabdomyoma. And here is the postnatal appearance in the MRI again. And when you see both lesions together in the same patient, this is what arises the suspicion. You see the skin, this is the rhabdomyoma, and this is the astrocytoma in the brain. Actually, tuberous sclerosis depends in the prognosis on the site and size of the lesion, and there is a combination of symptoms including developmental delay, seizures, behavior problems, and according to the site of the lesion, we have heart, lung, and kidney disorder. To conclude, prenatal sonography using high-resolution 3D and 4D ultrasound and in expert hands is a reliable and accurate mean for diagnosis of congenital CNS anomalies causing pediatric seizures. Prenatal sonographic diagnosis of congenital CNS anomalies causing pediatric seizures has several advantages. Number 1, it let the parents recognize the real magnitude of the problem. Number 2, it allows better communication with the pediatric neurologist involved in the management of the newborn infant. And this gives better chance for early institution of therapy. And finally, there is better chance for counseling for termination before viability instead of long-lasting treatment of fetuses with lifelong neurological handicapping disease. Thank you very much.
Thank you, Professor Muhammad, for this very illustrative and comprehensive talk.
Now we will continue in the same line of diagnosis, Professor Dr. Muhammad Abdel Nabi from Alexandria University, who will talk about cavum septum cerebellar diameter ratio and anomalies.
Good morning. Thank you very much, Mr. Chairman, co-chairman, and my colleagues. This talk is not different from some of the ultrasound images presented by my colleague, Dr. Muhammad Ali, but we may add some interesting finding for the diagnosis of abnormal corpus callosum. As he mentioned, the corpus callosum is a major commissure between the two cerebral hemispheres, and it is composed of axons or white matter fibers connecting the two cortices of the cerebrum on both sides. When to visualize the corpus callosum starts to develop by the age of 8 weeks till 20 weeks, and by ultrasound we can see the cavum septum pellucidum and the anterior part of the corpus callosum, and we can see the complete corpus callosum after the age of 19 weeks by ultrasound. This is the fibers connecting both hemispheres constituting the corpus callosum, and in the mid-sagittal plane we can see it as a C-shaped structure in the midbrain, which is composed of almost 4 parts. The anterior part is rostrum, the genu, and the body of the corpus callosum, and the most posterior part is a splenium. And within the center of the corpus callosum we can see the cavum septum inside, and below the corpus callosum we have to look for the thalamus and third ventricle below. How to visualize the corpus callosum? We either use the ultrasound or the MRI. By ultrasound we can use the axial plane, the mid-sagittal plane, the coronal plane. Using these modes, the 2D ultrasound, Doppler ultrasound is helpful in some cases, and 3D ultrasound is best to see the corpus callosum in almost all cases. Regards approach, we can do it transabdominal or transvaginal according to the presentation of the baby and according to the gestational age. This is the axial view for the fetal head. One of the first and easiest signs to diagnose the presence or absence of corpus callosum is the cavum septum pellucidum, which is present in the junction or at the junction between the anterior third and posterior thirds, 2/3 of the midline. And failure to visualize the cavum septum pellucidum may raise the possibility of absence of corpus callosum. This is not absolutely, because we can see cavum septum pellucidum in some cases of agenesis of corpus callosum. The second one is the teardrop sign. This is due to dilation of the posterior horn of the lateral ventricle. At the same time, we have narrow anterior horn and wide interhemispheric fissure. This is what we call colpocephaly or the teardrop sign. The best is to scan the corpus callosum in the mid-sagittal plane, where you can see all parts of the corpus callosum. But this is not usually visible in all cases, so we can use either the 2D ultrasound when it is visible, or we can use the 3D ultrasound, and then we do reslice of the volume of the corpus callosum in the sagittal or the mid-sagittal plane. This is a normal corpus callosum, and this is the mid-sagittal plane for a case of absent or agenesis of the corpus callosum. You can see here the corpus callosum and differentiate the different parts. Now in the coronal plane, in the mid-coronal plane or the transcaudate view, it allows visualization of the anterior horn of the lateral ventricle. In the normal cases, they are very close to each other, and they are separated by the interhemispheric fissure. And in cases of agenesis of corpus callosum, there is widening of the distance between the two frontal horns of the lateral ventricle. So the genu of the corpus callosum, the cavum, septum, pellucidum, and caudate nuclei, all of these are interrupting the continuity of the interhemispheric fissure. This is a mid-coronal view. Here you can see the midline, and this is the genu of the corpus callosum, and this is the anterior horn of the lateral ventricle or the frontal horn, and this is the cavum, septum. Look at this image. This is a case of agenesis of corpus callosum, and you can see here what we call the inverted T sign reported in the normal corpus callosum, and it is absent here in absence of the corpus callosum. Again, if you measure the distance between the two anterior horns, there is wide interhemispheric fissure, or what we call the wide anterior complex and posterior colpocephaly. Wide distance between the anterior or the frontal horns of the lateral ventricle may give us what we call the bat wing appearance or sign, plus the high riding third ventricle as mentioned by my colleague. Another one interesting sign is a sunburst sign in the para mid-sagittal plane of the to obtain the corpus callosum. If you move somewhat laterally to the right or to the left, you can see the sulci and gyri arising from the corpus callosum upward, and in cases of agenesis of corpus callosum, they arises or seen that to arise from the thalamus directly, giving this interesting sign. Regards the approach, we have the either transabdominal in the second or third trimester when it is cephalic or breech, and in the second or third trimester we can do transvaginal ultrasound, and this will give us much better delineation of the corpus callosum if we do it transvaginally late in pregnancy in cephalic presentation, because at that time it is much more difficult using transabdominal scan. When it is difficult, 3D could be offered, and we can do our cut in the mid-sagittal plane, and easily you can obtain the whole parts of the corpus callosum. We can see here this is the cavum, and this is the corpus callosum. Again, in some cases we may resort to the high definition Doppler to demonstrate the pericallosal vessel. Complete visualization of the vessel ensures the presence of the corpus callosum, and the presence of part of the artery could be seen in partial agenesis of the corpus callosum. This is MRI diagnosis for normal corpus callosum, absent corpus callosum, and partial agenesis of corpus callosum. What is normal for the corpus callosum? All segments should be seen and should be normal. The length of the corpus callosum should be normal, thickness should be normal. In addition, no abnormality should be present, like lipoma, wide interhemispheric fissure, abnormal cavum septum, abnormality in the anterior horns, and so on. In this publication, they provided biometry for the different parts of the corpus callosum, including the length of the curve of the corpus callosum, its length from outer to outer, its length from inner to inner. Again, they measured the thickness of the different parts, the rostrum, genu, body, and splenium. And these are the biometric measures provided by those authors, starting from 18 to 23 weeks. These are the thickness of the different parts by the same author. Now, abnormalities could be developmental, include hypoplastic corpus callosum, hyperplasia, agenesis, or degenesis, and the agenesis could be complete or incomplete. Regards the incidence, it is 0.3 to 0.7 in general population, and it's much higher in cases of developmental disability, and it could be chromosomal, monogenic, or teratogenic. This is regards the etiology. And by the diagnosis for corpus callosum abnormality could be achieved by the conventional measurement of the corpus callosum, but this is, as I said, not visible for all cases, so we resort to 3D ultrasound and do reconstruction and recut in the mid-sagittal plane. And in many cases, it's not easy to put a cursor between the outer or the interface between the corpus callosum and surrounding brain tissue. But it is much easier to put a cursor between the hypoechoic or occluscent cavum septum and the surrounding echogenic corpus callosum. And this is the idea of our study. It's much easier to measure the length of the cavum septum than to measure the whole length of the corpus callosum. So we started to apply this in our unit, and then we have observed a very interesting finding that the length of the corpus callosum, the length of the cavum septum from inner to inner is almost equal to the maximum transverse diameter of the cerebellum for the same baby. So the objectives of this study was to provide nomograms for the cavum septum length in sagittal view of the normal fetal brain, and to study the correlation between the cavum septum length and transcerebellar diameter, what we call the CC ratio, and gestational age in normal cases, and to explore the possibility of using this CC ratio for diagnosis of the corpus callosum abnormality. We examined 210 cases by 2D ultrasound and 3D ultrasound, and some cases with a Doppler ultrasound. Structures to be documented: the cavum septum, pellucidum, the midline echo, the anterior complex, salami, lateral ventricle, third, fourth ventricle, cerebellum, the corpus callosum in sagittal plane, and Doppler. And we end by 191 cases ranging from 19 to 34 weeks were available for analysis. The volume of intracranial structure was taken with reference plane at the cavum septum pellucidum in the axial. The multiplanar mode adjusting the point of meeting of the three planes at the cavum septum pellucidum. Then we shift to the TUI and minimize the distance between slices up to 0.5, and then magnify in the C plane to visualize the corpus callosum and cavum septum length. The cavum septum length was measured from anterior to posterior, from inner to inner, and also the maximum transverse diameter of the cerebellum was measured, and then we calculate the ratio. As you will see, this is the cavum septum length, and this is the cerebellum maximum transverse diameter, and we divide both together. What